Take a look at it. And that tells us it is ready to get started. So welcome, everyone. This is going to be a discussion on H5N1. It's called avian flu. Many of you have heard a lot about it in the news. Really thrilled to have an excellent panel today of distinguished speakers. And we'll be spending a lot of the time, the majority of the time, in discussion. This webinar is presented by the Region 1 Disaster Health Response System, also known as the RDHRS, in collaboration with the Regional Emerging Special Pathogens Treatment Center, the RESPTC at Mass General Hospital. Both of these programs are funded by the Administration for Strategic Preparedness and Response, or the ASPR, within HHS, so we really are very fortunate to have that support from the ASPR. This is our disclosure, so available to you. I won't read it, it's just available to you here. So let's get into introduction. So my name is Erica Shenoy. I'm the Chief of Infection Control at Mass General Brigham. I'm an infectious diseases physician at Mass General Hospital and serve as the medical director for the RESPTC at MGH. We have a terrific lineup. So David Hamer is a professor of global health and medicine at Boston University, and he is the co-lead for climate change and emerging infectious diseases at the BU, or Boston University Center on Emerging Infectious Diseases. We have Dr. Nahid Badilia, who is an associate professor at the Boston University School of Medicine and founding director of the BU Center on Emerging Infectious Diseases. We're pleased to have Dr. Tim Uecke, who is the Chief Medical Officer in the Influenza Division at the Centers for Disease Control and Prevention, and Dr. Catherine Brown, who is the State Public Health Veterinarian and the State Epidemiologist here in Massachusetts at the Massachusetts Department of Public Health. So as you can see, a terrific lineup of speakers. The learning objectives are here and they were on the flyer, so I won't spend time on this, but I will turn it over to Dr. Uecke, or Tim. I'm going to turn it over to you for the intro. So this will be about 10 minutes where we're all going to set the stage of where we are today with H5N1, and then we'll get into our discussion. So Tim?
Thanks, Erica. I'm going to give a little bit of background on H5N1 and a little bit about CDC activities. So actually, the focus is this highly pathogenic avian influenza A H5N1 virus, and actually it was first detected during a poultry outbreak in Scotland in 1959. One thing about this virus, along with all influenza A viruses, they continue to evolve very dynamic. And the first time this really came to our attention in terms of global public health concerns was in the outbreak in Hong Kong in 1997, in which there were 18 cases and 6 deaths. And this is the first time that we realized that a virus, an influenza A virus from poultry or birds, could go directly to humans and cause fatal infections. So to date, since 1997, there have been 912 human cases reported in 24 countries. These are really sporadic cases. The case fatality proportion, however, is about 51.5%. which is pretty alarming historically. Now, the focus of this situation globally and in the US now is this particular clade or group that we call 2.3.4.4b viruses. These emerged in wild birds around 2020. They continue to evolve through reassortment and endogenic drift. These were first detected in wild birds at the very end of 2021 in North America, and they've caused poultry outbreaks. They've caused a wide range of wild bird infections, many different species, and spill over into infected mammals, and this continues to go on. But just to say, there are other clades of this H5N1 virus that continue to circulate among wild birds, cause poultry outbreaks globally. Next slide. So this is an epidemic curve of human cases since 1997. You see the Hong Kong outbreak at the far left, and then a lot of different countries have reported cases, up through 2015, which was a big epidemic in Egypt. But since 2015, you can see a big drop-off in human cases and just a small increase on the bottom right. Since 2022, there have been 29 cases reported in several countries. Some of these are probably not real infections. They met criteria for reporting to the WHO. They were detections in asymptomatic poultry workers, but clearly there have been some severe and critical illness, including fatal outcomes reported. In Cambodia, it's a different clade of virus than this 2.3.4b virus, but there was a fatal case with this particular clade in China. Next slide. So there's a one thing about these viruses, though, they bind to the respiratory and gastrointestinal tract of birds, but in people, they really bind preferentially to receptors in the lower respiratory tract, and they do bind to receptors on conjunctiva. We think the real concern would be if these viruses are able to bind to receptors that are prevalent in the human upper respiratory tract, which we have not observed since 1997, never have observed this with H5N1 virus. Since there's a wide clinical spectrum from very mild illness, conjunctivitis, and just uncomplicated upper respiratory tract illness to severe pneumonia, respiratory failure, sepsis, multi-organ failure, and death. The risk factors historically have been really exposures with poultry, sick or dead poultry, visiting a live poultry market. But there have been a small number of cases attributed to exposure to wild dead swans or to dairy cows in the US, and a very small number of cases from limited non-sustained human-to-human transmission, not reported since 2007. Next slide. So the current situation in the US, USDA announced on March the 25th detection of this virus in dairy cattle in 2 different states. And now, as of this morning, it's 12 states that USDA has confirmed this virus to be in dairy cattle in at least 95 farms. And of note, this virus is detectable at very high levels in the raw milk of infected dairy cows. A wide range of species, mammal species, including other livestock, baby goats. And I'll just say since February of 2022, we have had a lot of poultry outbreaks in the US. There have been about 97 million poultry or backyard flocks in the US that have either died or been depopulated to control the spread. So it's predominantly been a poultry impact in the US. And now we're dealing with this outbreak in dairy cows. Next slide. So up to date in the US, in 2024, we've had 3 cases attributed to cattle exposure. All 3 were in dairy farm workers. 2 of them had conjunctivitis only, and the last case in Michigan had acute upper respiratory tract symptoms. Some complaints of watery eyes. Actually, conjunctival swab testing in that individual was negative. I think actually this was overlap with seasonal allergies to explain the conjunctivitis there. But at any rate, these were clinically mild cases. None were hospitalized. We recommended home isolation. We offered antiviral treatment as well as post-exposure oseltamivir chemoprophylaxis. No secondary cases resulted. We were able to isolate virus from the first case in Texas and this first case in Michigan. Next slide. So one of the things when we look at the sequences, there's no impact to diagnostics, at least the CDC real-time assay and the real-time H5 assay will detect this virus. All public health laboratories in the US have the ability to detect, to use our assays to detect this virus. However, there's a positive result for H5. We want those specimens sent to CDC for confirmatory testing. The good news is that when we look at the sequence data, as well as at least with the first virus, look at it in some in vitro assays, there's no markers of resistance to the antivirals we recommend for seasonal influenza. However, specifically for H5N1, we recommend oseltamivir for treatment and for post-exposure prophylaxis. As far as routine pandemic preparedness, we're always working to make candidate vaccine viruses. This predated this detection in cows. We've been doing this because of poultry and other wild birds. We have 2 candidate vaccine viruses that would be a pretty good match for this clade if they were if vaccine production were needed to be ramped up. Next slide. So we're when we've looked at all these different surveillance platforms that we have traditionally for seasonal influenza, some of it's syndromic. We've also looked at ED visits, hospitalizations. There's no indicators of unusual influenza activity in people. One of the things is we're lucky right now, influenza activity typically is quite low across the US. It is not zero, and it's never zero in the summer months, but it's very low. Now, on the bottom right, you see a map. You probably can't see it too much, but that's wastewater data. So it's another tool. It's being used to integrate with all our surveillance activities. If we see a signal for wastewater for influenza A detection, then we work with state and local public health partners to kind of investigate. And the most likely explanation is that is not attributable to human influenza infections, but it's in fact animal sources. Could be poultry, wild birds, or dairy cow, and particularly raw cow milk. Next slide. So over the summer, our priorities are really to continue supporting state and local public health to monitor workers with exposure to dairy cows that are sick at confirmed farms, and to test them ideally, and monitor people for 10 days after their last exposure. We are supporting our public health partners to test any concerning influenza A positive specimens. We do want our states and local public health across the country to ramp up subtyping of any influenza A positive. It's a way we can kind of monitor any potential signals in influenza A activity that we might be missing. Invariably, it's going to be seasonal influenza A, but we do not want to miss them. I'll just mention that the summer months is the agricultural fair season, county and state agricultural fairs. That's another area we're working with, not just typically because of swine influenza or variant virus infections, typically of kids, but because there could be dairy cattle that's also mixing and exhibited at these agricultural fairs. So we're really trying to work on all these different surveillance systems and continuing this throughout the summer. So I think, next slide, I think I'll just stop there. Thanks.
Awesome. Thank you, Tim. That was a terrific summary and where we are up until exactly today. So get out your clickers. What we're going to do here is I'm going to launch a poll, and what we want the audience to do is to say, where, based on everything you've just gotten the update, where do you fall in terms of how closely you are tracking on H5N1, and what you, in whatever capacity you are, either if you're public health or if you're a clinician, if you're in an operational role at a healthcare facility, what are you doing in terms of your preparedness? So once the poll launches, are you kind of low concern, you're following it, but you're not making any major changes to your preparedness? Are you in the moderate concern camp where you're following this pretty closely and you are planning to make some changes to preparedness activities? Or are you in the high concern bin where you're following very closely and you're not only planning, but you're implementing major changes to your preparedness activities? So I'm about to launch the poll, and hopefully I will be able to do this technically. And I will relaunch yes. Okay, so okay, people are voting, which means I actually technically did this. So this is exciting. We're almost there at the top. Definitely do your clicking. And what we're going to do is at the end of this, I'm going to ask the speakers where they are. And then we're going to take the poll at the very end of this session to see if there's been any movement in terms of where people lie. So we've just got a few more people who are voting. I'll stop this at 30 seconds. So get your clicker in there if you're going to vote. And then I'm going to end the poll. Okay, stragglers, last chance. And you're in. Okay. So let me, before I share the results, I'm going to go through the panel. I'm going to ask them to say where you are, low, moderate, or high. So I will start with Tim. Where are you on this?
So I'm a little different because I work on influenza and I'm heavily engaged with the CDC response. So I will just want to say that we think, and I think, the risk to the general public is quite low. It's increased for people who are exposed, particularly workers, poultry workers and dairy cattle workers at affected farms. And so for me, again, very different than probably the rest of the panel, I have high concerns because this is my job. So that's how I'll.
Okay, Tim, it's your job to have high concern, so you get that. David, where are you on the spectrum here?
I'm moderate concern. Yeah, I mean, I am worried, but I think that we need to actually have CDC do their job and state public health departments, enhance surveillance. We need to be doing things to protect dairy workers, but I think that there's not enough evidence yet to really worry. But we fortunately have the tools also. We've got antivirals. We can scale up vaccine production. We don't need to do that yet, but we need to be ready to do that.
Cool. Okay, Naheed, where are you?
Yeah, I put myself in the same category, and I'll echo what David and Tim said in terms of the fact that it's probably a much higher concern in terms of making sure that workers that are exposed to potential animals that are infected are getting surveilled, are getting the care. But I will say one other thing is that, in general, I think the public needs to understand that it's not like a low risk and crisis, right? My thought has always been you need to have multiple levels in between. And if you sort of think about it in that way, I don't think we're at 0. We're probably at 1, even for the general public, because we're talking about unpasteurized milk and the risk of that. We're talking about county fairs. I mean, this summer I saw one of the states are now going to require testing of animals before there's petting zoos. I mean, so things are changing, practices are changing. So it's not at 0 for the general public either. It's the only thing to mention.
Terrific. Katie.
Yeah, I just want to plus one to everything that everybody has said. And also also to acknowledge that I think a lot of us are having sort of a mixed response. One is from kind of our brains and from the science side of this. And I mean, maybe I'm the only one, but I actually don't think so. But wherever your anxiety sits in your body, for me, it's in my GI tract, right? Like I just, because we've just gone through COVID, I think sometimes I'm like, but what if? But in, really answering this as a scientist, I'm going to go with moderate concern as well. I'm following this very closely. We have already made some changes to our preparedness activities at the state level, which I think are consistent with what CDC has asked us to do and also consistent with what I see other jurisdictions doing. I am very confident in our CDC subject matter experts and appreciate that they are at high concern. And I also know that they will tell me when when it's not just my GI tract telling me to be nervous, but that we really need to ramp things up.
Terrific. So I'm going to share the results. Are people seeing the results now? Give me a thumbs up. So that's where our groups, we got 68 people of the 102 here, although some of those 102 are on the panel. So it looks like a good distribution. So let's see, I'm going to memorize this look so that we can see where we are at the end of the session and compare. Okay, so with that, I'm going to take down the slides and we are going to go into the discussion panel. Okay. David, you are up first. From your perspective, are there any unique aspects of H5N1 with respect to transmission, clinical evaluation, management, and impact that are important to recognize and plan for? And then can you put this into context about how we plan for and manage seasonal influenza each year?
A couple of unique aspects. I mean, I think as Tim has described, that the 3 people who, at least in the humans that have had infection in the U.S., 2 of the 3 had conjunctivitis, and but they all had dairy cattle exposure. So I think right now we have some fairly clearly defined risk groups that basically exposure to cattle. Especially dairy cattle, and that can help us. I think that's a group that we need to help protect, so they minimize their risk of exposure. But B, the manifestations they've had have been mostly, at least 2 out of 3 are conjunctivitis. One you said had watery eyes, but that might have been a seasonal allergic rhinitis. And I sort of wondered also about that person because they had some upper respiratory symptoms, and yet what we know about this virus is it seems to be more likely to bind to the lower respiratory tract. So we haven't seen really a severe pneumonia yet, at least in the US. And knowing, historically the data, I mean, this is a very severe disease, and in areas where it's been associated with especially backyard poultry, with a case fatality rate of about 50%. And so that, that worries me, but the jump has not been made yet. So I think right now we need to be thinking about screening people that have contact with animals, but both birds, domestic and wild birds, as well as cattle. The question is going to be, if other animals start to develop infection, including, I think you had cats on there. What if it starts to be found in domestic animals, our own pets? That would really change things. And then in terms of sort of symptomatic screening, I mean, this is not yet showing itself, at least in the US, to be an influenza-like illness, the classic fever and systemic symptoms. So I'm not sure using those kinds of definitions, which we would normally use in the fall and winter, are going to be helpful. I think the one other aspect comparing sort of usual seasonal screening is we try and raise awareness, especially during the fall, winter, because that's when we usually see influenza, with the exception of maybe the H5N1 outbreak in 2009, when it started more in the spring and summer. But I think we need to be aware all year round of the risk and be sort of have heightened awareness to be ready. And then the testing, it becomes very important. I think we need to make sure samples are getting to state laboratories, or laboratories have the capacity both to test for influenza A, but also do the subtyping so that we can identify H5N1, potentially more rapidly.
Terrific. Thank you. I'm going to turn this to Katie now. So there was a recent CDC report that was basically modeling the potential here for H5N1, and under a variety of assumptions, thought that novel influenza infections in humans would be detected using existing healthcare surveillance. So similar to what Tim was showing, we have a lot of different ways that we're doing surveillance. Can you comment on this finding and maybe tell us a little bit about, from the state perspective, how you're ensuring right now that we are prepared and our ability to detect human infections is where we need it to be?
Yeah, thanks for that question. So I want us to sort of split surveillance into two sections. One is the ongoing surveillance that's happening with people who have had known sort of close direct exposure to infected birds or dairy cattle or any of the other species that we have found this particular virus in. So I think we've already heard and acknowledged that this is a particularly high-risk group of folks, and public health is working with individuals who have been exposed to help them with symptom monitoring, and then can help with coordinating testing for flu A and H5N1 specifically, if a high-risk person like that ends up being exposed. What this study was actually talking about was sort of not this higher risk group of people, but if this H5N1 or another novel influenza virus started to circulate and became really, we saw sustained human-to-human transmission, that the modeling was looking to figure out how likely would that be detected through the existing healthcare surveillance. And actually, I think it shows they have a fair amount of confidence that maybe not every case would be identified, but a case would be identified. And you only need one to tell you that something is happening, right? And Tim has already talked a little bit about some of the surveillance tools that we use. So I'm just going to briefly kind of add to that a little bit. So there's a national ILI net. So this is outpatient kind of viral respiratory illness surveillance, where Sentinel providers let us know the number of influenza-like illness visits that they have as a proportion of all visits, which helps us understand sort of what proportion of respiratory illness that outpatient providers are seeing is likely due to influenza. There's also a very important, a couple of different ways to look at flu severity, so hospitalization related to influenza. And Tim mentioned one of the ways we do that, which is FluServNet. It's kind of another sentinel system, but then also syndromic surveillance is something that many jurisdictions are using, including Massachusetts, where we're looking at our emergency department data in pretty close to real time and looking at the number of people hospitalized for influenza. There's a lot of laboratory surveillance that goes on looking at the viruses and trying to report the proportion of people who are tested for suspicion of flu who end up testing positive. And then a subset of those laboratory results end up getting further genetic and antigenic characterization, which would help us identify novel strains, and also looks at antiviral resistance, which is of course another significant component. And then there's mortality associated with flu, both in pediatric and adults. Wastewater, as Tim mentioned, is another important surveillance activity. So I think the completeness of all of that is going to help us identify a novel influenza strain if it maybe I'll say when it arrives, because it will happen at some point.
Thanks, Katie. I'll just ask one thing that came through the chat was related to ILI surveillance. There was a question, do all states report ILI surveillance? Are you aware, or is it selected states?
Tim might actually have a better answer to that.
So as part of influenza surveillance, states are reporting to CDC visits by sentinel providers, right? These are outpatient providers, right? It's primarily primary care. There are some emergency physician sites. So they're reporting for total numbers of ILI patient visits and then total numbers of patients with influenza. And so what we look at is sort of the percentage of influenza positives of those. So yes, all states are reporting weekly ILI data, but ILI, as Katie pointed out, is syndromic, right? It's very non-specific. So it's a tool, but what we really need is the specific virologic testing.
Thanks, Tim. Nahid, so the CDC recently sequenced one of the human cases. Question to you is it correct to assume that public health will continue to do the human sequencing, poultry and dairy cow samples as well to understand mutations with viral adaptations? And also, can you tell us a little bit about how to assess if specific mutations, which are starting to be reported, will lead to increases in transmissibility, severity of infection, and whether or not the medical countermeasures that we have, either therapeutics or vaccines, will be continue to remain effective?
Yeah, thanks, Erica. And of course, we'll ask Tim to also weigh in where I say something that might not be right. Let me step back and just answer that first question. So I believe the CDC has now sequenced all the human case data, that the cases that are available. For one of them, my understanding was that there wasn't enough quantity sample, and there was a concern because the cycle threshold was a little high in terms of the number of times they had to be amplified to be able to get the amount to be able to do genomic genomic analysis. The concerns to date have been that in the samples that they have looked at in the two humans, there's two mutations that show mammalian adaptation, an E627K and a PB2M631L. This means nothing. Let me just say what it actually means is that there are potential changes in the virus that could help it to further adapt to mammalian respiratory or other sort of physiological systems. The way that most of the genomic surveillance happens, to your question of will public health keep doing this? Yes. So stepping back about how phylogenetic analysis, which is basically doing an entire genomic surveillance look at the virus to see if any sequences have changed. The way that happens is that you first need the samples, either diagnostic samples or environmental samples that have been collected. either the cows, the cats, something has had a sample given. I'm doing this on purpose to stress why this is important. And then that needs to be then genetically analyzed to see if there are changes. Trouble has been, in my view, and I can say this because I'm no longer in government, and one of the things is that we're not seeing as enough sequences being shared. And partly it's because there has not been as much access to farms as possible to do the level of the type of both environmental as well as diagnostic testing that we need to be able to do two things. The first thing is transmission related, right? What do these sequences tell you? They tell you the direction of transmission. If you have a lot of samples that you're able to do genetic analysis on, you have a much clearer understanding of how transmission is happening on farms, which way things are flowing. The understanding so far is that what happened was an initial spillover from birds into humans in December 2023. I almost said December 2019, 2023. And that subsequent infections in humans, as well as other animals on farms, have come from dairy farms. That's important. So that's what phylogenetic analysis has been able to tell us so far. But getting additional samples helps us flesh out a bit more about, how many times these transmissions are happening. There's just not enough testing for us to get a bigger picture or more understanding of the geographic location, right? To build a story about how a disease is traveling, you need to know the where, when, and the who. And in the genetic samples that have been shared, the sequences that have been shared, we actually don't have even geographic locations of where they're from. So it's kind of hard to do that analysis, at least for those scientists who are outside of the government to be able to do that. So that's one part that genetic analysis can do, and I think it should continue. And what I'm hoping is that there is greater collaboration between farms and public health bodies at the state level and at the federal level, that we will be able to do a greater amount of testing that helps us flesh out some of that story. So in terms of how those samples are then used to look at transmission, how they're used to look at medical countermeasures and other aspects of the disease severity, a few ways. It's phenotypic and genotypic analysis, right? So we just talked about genotypic analysis. I think looking at the sequences to see if they may have any mutations that may raise concerns about the effectiveness of candidate vaccine viruses or known resistance markers for antivirals, or known, further adaptations to human mammalians or respiratory symptoms. Those are things that could tell you from a genetic perspective, if the virus is changing, that it may affect, the disease in some way. Phenotypically, the way that it can be done is animal models, and CDC released end of last week a ferret study where I believe the findings were quite similar in that ferret study to what was previously been seen with other, and Tim, correct me if I'm wrong, with other serotypes of the same H5N1 that have been seen in the past. Then it's actually looking at the sera, the vaccinated, using the same viruses that have now been gathered to test in laboratory against candidate vaccine viruses. Of virus vaccines is another way to test whether or not the effectiveness against the known currently stockpiled vaccines will continue to be effective or not. So genotypic, phenotypic analysis, as well as use of the sera to see if there is going to be enough of an immune response based on the vaccines that we have in stock. I don't know if that answers the question. Oh, by the way, I will add, transmission studies are the hardest to do. So how would you do the transmission studies? I think animal models probably, but I'd love to hear what David or Tim or Catherine have to say, because you can't do that in humans, of course. So you'd have to do that through either engineering studies or animal studies.
Yeah, maybe let's ask that one question about how can we do transmission studies. I'll ask Tim and then David maybe to weigh in, and then we'll keep going with what seems to be a common theme here is that we need more testing, more situational awareness, and so much derives from that in terms of all these additional studies we need to do to truly understand the potential risk. So Tim, thoughts on on transmission studies, and then David?
Yeah, so the accepted animal model for influenza virus transmission is the ferret model. And he'd mentioned one of the studies, and she mentioned, she's commenting about more pathogenicity So this virus, when you inoculate ferrets intranasally, can kill ferrets. And most H5N1 viruses, but not all that have been studied in the ferret model in the past, can kill ferrets. So that is very different than seasonal influenza viruses. They don't kill ferrets. Ferrets might have a little bit of weight loss, but they do not get severe disease. This virus clearly can cause severe disease and fatal disease in ferrets. Now, in terms of transmission studies, the main kind of model that's done is both there's two. One is called a direct transmission model, and the other is more of an airborne model. So in the direct transmission model, you intranasally inoculate one ferret, and you put other naive ferrets, susceptible ferrets, in the same cage, and then you look to see how many ferrets of those susceptible ones get infected. So in this experiment that Nahid mentioned, alluded to, all the ferrets got infected in the direct contact model. And that is also the same findings that were found and actually published with other non-CDC studies, both in a virus that was identical. It wasn't the exact isolated virus, but it was from the same clade of virus from an infected mink during a mink farm outbreak in Europe. And so that virus also transmitted in the direct contact model very well. The other model is the airborne model, where you have an infected ferret, and then you separate them in another cage with susceptible ferrets that you have small holes. And so if there is infection in the susceptible ferrets in the other cage, that's either through some droplets or very fine, we'll just use the term infectious particles, airborne transmission. And so in the studies that have been done with the mink virus, as well as my colleagues' studies, unpublished but were released last week, there was very inefficient transmission through this airborne model. So that's actually a bit reassuring. Now, when we compare that to seasonal influenza virus infection of ferrets and transmission, all of those infected ferrets will transmit through that airborne model. So that just kind of, shows what goes on in people. We know seasonal influenza viruses transmit very well person to person, but H5 viruses right now transmit very poorly to and among people. And we think one of the main changes that would be needed is that the virus would need to switch receptor binding tropism to bind to these alpha-2,6 linked sialic acid receptors that are most prevalent in the human upper respiratory tract. That's not to say that the alpha-2,3 sialic acid receptors, which this virus does bind to, are not present in the human upper respiratory tract. It's just that they're much, much more prevalent in the human lower airways. So, a lot of people look at this as sort of a upper versus lower. It's a little more complicated than that, but we think if this virus acquired the ability probably through passages in mammals, and that's actually what's going on right now. We have a natural experiment where this virus is passaging from cow to cow. The concern is, will this adapt in mammals to actually bind better to these alpha-2,6 receptors that are prevalent in the human upper respiratory tract? We can talk about that. The virus right now has not shown this, and so that's good. But this is one of the main changes that we're looking for, and the concern that it's being established in a mammalian host. We're really not seeing this. There's probably been some marine mammal to mammal, particularly in seals transmission. Thousands of seals have died in some of these outbreaks. And it's probably both environment, bird species to mammal, but it's probably some mammal to mammal. But at least it hasn't really gotten established in any mammals until it appears to be becoming established in dairy cows now. And that's a concern.
Well, just one thing I wanted to say to follow up what David and Tim had said is that we're talking about how this is not severe, which is true. The 3 cases that we've seen have not been severe. Just the 2 pieces of caution that I want to add is I believe CDC, again, Tim can correct me if I'm wrong, has only received 40 something, under 45 samples to be tested, and it's just, it's an environment where workers may not be coming forward for illness. So we don't actually know, how much other illness in my mind there is that's out there that we're not picking up. But clearly, there isn't clearly a big jump in hospitalization because we would have picked it up. A big jump in ED, we would have picked it up. But, the level of presentation, we just don't know. But also in the current state of the virus, one thing to just be cognizant of is that person to person, the susceptibility also changes. Your immune, your level of immune sort of competence, the amount of virus you were exposed to in that period of time. So just keeping that in mind in terms of how disease may also just present differently, even in the current viral sort of genetic composition.
Thanks,
my-
Libby.
My
Yeah,
quick comment would be that there's no question that the risk of human infection is animal to human. So this is a zoonotic disease, and it's people who are exposed have unprotected close or direct exposures, and typically prolonged exposures. But the key is unprotected exposure to an animal that's infected. And historically, we've seen that with poultry exposures. But clearly, we have 3 human cases. They've been clinically mild with direct or very close exposure to infected dairy cattle. I think that everybody that's been working on this or looking at this situation would say that surveillance in humans who are exposed is suboptimal. Now, this is something that takes a lot of time. This is a big collaboration, One Health. It's a very challenging situation. A lot of the worker population is non-resident. Many are non-English speaking. They actually are concerns about any government, whether it's public health or not. This is something that takes time. We've worked with states and local health departments and farm owners for years in terms of poultry outbreaks. It's also true for swine influenza and the industries. But this is a really new kind of situation now. So it takes time to build up trust in the workers, trust in the farm owners, trust in the industry, trust with our animal health partners, and public health, everyone working together. And Michigan is the only state to date that's really been able to do the most in terms of really monitoring exposed workers and actually be able to test symptomatic workers. And so clearly there have, been workers who anecdotally have been symptomatic, who have not been able to be whether they had some other etiology such as seasonal respiratory viruses, as the etiology of conjunctivitis or acute respiratory illness, to what extent allergic, allergies might be a component, or to what extent H5N1 virus infections could have been missed. And so this is something that I think all levels are trying to really improve surveillance. And, all the other kinds of surveillance activities that are being looked at are both to monitor the current situation, but it also is part of pandemic preparedness. If if things are happening, transmission is occurring that actually is not being captured. So I think a lot more needs to be done collectively. If I were to say, what's the single most important issue to sort out? It is a history of recent animal exposure. That is the number one thing. It's not the general public that's, to what extent having or consuming raw milk is an issue. That's a totally unknown area. It's theoretically possible. And so that is one area that's a little bit beyond just the worker exposed population. So we need to do a much better job at both protecting workers, but also monitoring and getting their cooperation.
so let me shift over and actually go to Katie first to talk about the public health perspective. And also, I think it was interesting the case of Michigan and what Michigan is doing, but also the One Health angle. And then I'll move over to David and the potential for any climate change component or aspect of all of what we're seeing right now. So Katie and then David.
Yeah, thanks for that, Erica. You know, this is a highly sort of clinical and public health oriented audience. And so I think most of the conversation has been around the pandemic potential and making sure that we are maintaining a posture of readiness to respond in case we start to see a pandemic emerge from that. And I don't want my comments to take away from the importance of any of that, right? My job is public health. That's also what I focus on. But as a veterinarian also in the public health field, I just want to refer back to what Tim was talking about in terms of One Health, right? So this is a sort of an interesting situation where what we have right now is a fairly substantial animal health problem, right? We have this new disease in dairy cattle that the United States rely on as, you know, a food source, right? And I've seen sort of conflicting reports where some say, oh, it's not so bad for the dairy cattle and they recover and, you know, then life goes on. And yet I've also seen some pretty compelling evidence that actually some of these animals become very, very ill, and it's not clear that they necessarily recover to the extent that they can then eventually kind of come back to producing the amount of milk that they used to, right? Which is, of course, whether you like it or not, that's the life of a dairy cow. And so I want all of us to remember, as we're thinking about the potential human health impacts, that there are also impacts on the animals. There's impacts on the dairy farmers and the industry as well. And, you know, even if you don't individually care kind of about the dairy industry, anytime you have significant impacts to one, particularly a food production industry, it's going to have downstream, particularly economic consequences, right? For all of us. If milk becomes more expensive, then that's an impact for all of us. And one of the other things I think about is making sure that we can maintain confidence in the pasteurized milk supply, right? Pasteurization makes milk safe to drink. And that's not just for all of us, but particularly for some of our vulnerable population, like the WIC program that services women, infants, and children. We want to make sure that people are still confident that pasteurized milk is safe to consume, because it is a very important nutrient source for certain groups. And then the last thing I want to say is that I learned something very important during the pandemic H5N1 outbreak, which is it is truly critical for us to be focusing on H5N1 right now, but we can't do it to the extent of ignoring other possible threats, right? The pandemic H5N1 happened, and it caught us a little off guard, right? Everybody actually at the time was focusing on avian influenza, and we all thought it's going to emerge in probably Southeast Asia, and we're going to have some time to learn about what's happening before it hits the US, and we'll be able to be prepared. And then wham, it happened in Mexico and came to the US almost immediately. And so I want us all to remember that we can't just keep our eye on one ball. We have to keep our eyes on all the balls.
Terrific. Let me ask David, thoughts on the impact of climate change and how that may be playing a role.
Sure, just a couple quick comments. I mean, it's complicated dynamics, but there may be a number of ways that climate change and then aberrant weather patterns influence birds in particular, and bird migration patterns. And the range of some birds may shift. They may be working their way more towards the poles. And I wonder, you know, we've talked about some massive seal die-off, you know, the intersection between different bird species that typically didn't have a lot of crossover. And then speaking of crossover, I mean, the potential for virus reassortment if there is more contact between migrating bird populations and other species, whether they be other birds or other mammalian species. And there are other things that may arise. Food stress in birds can lead to changes in their immunity and their sort of increased susceptibility to highly pathogenic avian influenza. So, I mean, those are just a few ways that changing climate, but also changing weather patterns may affect bird migration and bird populations, but also lead to more reassortment and then movement of virus.
Wow, fascinating. Let me turn this over to Naheed. We're getting close. We have a couple more minutes before we re-poll everyone and see if people have changed their thoughts. And there's some questions in the chat that maybe I think, Tim, you might want to try to answer about the alpha receptors while we're doing this. But Naheed, if you're a couple things, oseltamivir, stalwart in terms of our ability to still use that. Can you tell us a little bit about what you think will impact whether or not we still have this agent available to us? And the second part is we're in summer now, we're about to go into fall. What are kind of the things that are top of mind as we start seeing actual seasonal flu over the course of the fall?
Yeah, I'm just going to keep it brief. I think for the first part, once again, I think this is why testing and genomic surveillance is going to be so important, because picking up whether there are mutations, particularly if we start deploying Tamiflu in a meaningful way and people who are getting treated with this, it's going to be important to follow that, because it's going to take a while for the vaccines that are under production that BARDA has commissioned for those to come in, the 5 million doses, right? So let's say something changes and all of a sudden we need to use treatment as our sort of first intervention in a pandemic setting. This is a treatment that needs to be given within the first 2 days of illness. So someone has to be identified pretty quickly to be able to give them this. My concern, aside from just the timing and making sure we're using it judiciously, is that there are people on the internet who are saying start stockpiling Tamiflu. Please don't start stockpiling Tamiflu. I mean, if you want to talk about why mutations may arise, it's because there's just rampant use without the right indications. That's just something that we don't want to do, and it has its own side effects, the adverse effects that we don't want to sort of have to deal with medically as well. In terms of the fall, I think the major issue that we're going to see is that if we start seeing more human cases, while there's other ILI-like symptoms that are going on, it's going to be a lot more important to start looking at genomics, greater genetic sort of analysis of every single influenza A virus that comes in to make sure that it's not an H5N1. One of the things that I've been sort of advocating for, and I think some states have started to do this, is that we tend to genotype a small percentage of the influenza. Public health labs tend to genotype a small percentage of the total influenza viruses that come in to keep this kind of, as I think, Katie and Tim mentioned, to make sure that there aren't any surprises. I think that I would advocate that we do a greater proportion, genotyping of a greater proportion of influenza A viruses that we're seeing, particularly in a scenario like the fall where we might start seeing other flu viruses circulating at the same time.
Thanks, Naheed. It just occurred to me that if more of the kind of commercial assays out there had the ability to subtype right then and there, that could actually help both from a clinical perspective and a surveillance, but it's only a limited number that give you that answer up front, at least that it's not, for example, non-subtypable, and that would might be a trigger to kind of get additional workup.
Well, just one thing to tell people, by the way, Tim mentioned this, that human and animal history, epi-history, is going to be so important for clinicians even going into the fall unless something changes. But I kind of want to say that your question shouldn't just be farm workers. I think it's really animal and mammal interactions, because there's so many 40-something species of mammals. Not that everybody's going out there, interacting with wild animals, and 96 million birds, right, since 2022. Yeah. So no interactions with dead birds, no interactions with barnyard animals. Just keep a view for that. And then just one last thing to mention for folks as CDC's guidance in the HOT, if you do have someone in the emergency room, you're testing for this, potentially collecting a sample, don't just collect a conjunctivitis, but also collect an NP sample, a respiratory sample at the same time. So 2 samples, regardless of what the presentation of the patient is.
Thank you. Okay, we're going to launch the poll. Get your clickers ready. Let's see where people are after this amazing session where we talked about a lot of things. People are voting very quickly. And just for reference, last time, when we started off, we were at 44% low, 50% moderate, 6% high. And as the The hour closes. People are voting. I'll show the results in just about 10 seconds. Participation, there we go. Okay, let me close this down. And looks like interesting. So people kind of segregated a little bit more into the moderate. The highs are just, they are where they are. It was 4%, now 6%. But yeah, so people are in the moderate, following closer now that they've had this session. So thank you so much to everyone. Let me just close out by saying what a terrific session. Thank you to our speakers. I learned a ton. Want to thank our sponsors, the RDHRS, the RESPECT, again, supported by the ASPR. The recording will be made available. It will appear on the RDHRS website, and we will be posting that, I think, pretty soon. I don't know exactly when, but thank you again to everyone who showed up today, and a round of applause for our speakers today. So thank you all very much for joining us. Great work. Bye, everyone.